fast. Okay. We already talked about bradycardia. Then, guys, so it's recorded already, so you guys can check it out, okay? And just really quick, I have YouTube channel that you can see other stuff, okay? Instagram channel, بس يعني it's more for patients. With Twitter accounts more for like electrophysiologists, okay? عموما, so we talked about bradycardia already. If I will not talk about bradycardia, we'll talk about tachycardia today, okay? Okay, so we'll start. Okay, so this is the first. Don't worry about the QR code because we wanna just keep going. So this is I would love for this lecture to be interactive. Okay, if guys don't be shy. Last session, people were very interactive, which was nice. So please be interactive. I don't know you guys personally. If I don't be shy from answering questions. Okay. Okay, so this is a 14 years old with leukemia and febrile. And someone called us worrying about the patient heart rate. Okay, so guys, what do you guys think? What do you guys see? And what's your what is this tachycardia type? Obviously the patient is a little bit tachycardic.
ده نارو كومبلكس تاكيكارديا.
Yeah.
البي اكسس هنا ساينس
Mm.
بوزيتيف 1 واي بي اف ونيجاتيف اي بي ار.
Mm.
هو اولموست ساينس تاكيكارديا.
Okay, excellent. Okay, فطبعا دكتور Ahmed, we talked about this last week or 2 weeks ago. So we said, I mean, it's a narrow complex tachycardia, but you have differential. بس طبعا in order to figure out the type of tachycardia, you want to study the P waves. And the P wave, as you can see here in lead 1, it's upright in lead 1, upright in lead 2, upright in lead. You guys can see my pointer, صح? Upright in lead 3, okay? And then upright in AVF, or sorry, AVL, AVF, okay? So in other words, the direction of the P wave is going from right to left, meaning positive in lead 1, which is the left lead. So you're going towards lead 1, okay? And it's going towards the inferior leads. So from up to down, because it's positive in lead 2, 3, and AVF, okay? In other words, this is exactly where you would expect the sinus node to be located, صح؟ يعني هذا heart. Okay, guys. So where's your sinus node? Somewhere here, صح? The direction of your atrial activation is towards the left, okay? And towards your inferior leads. مفهوم, guys? Okay? This is probably I believe this is very simple, so I imagine most people are gonna are understanding this. صحيح, guys? Questions?
تمام صحيح.
Yeah. Okay. Okay. Is it okay? This is a patient who is tachycardic, febrile, leukemic. So we said tachycardia, narrow complex. Then you have only two main differentials: sinus tachycardia or SVT of some sort. Because the P wave axis was normal, then this is most likely sinus tachycardia. Okay. طبعا you would expect the patient to be tachycardic given he's febrile and maybe he's anemic. Who knows? Okay. تمام, guys. طبعا if the P wave axis is abnormal, then it's an SVT. It's so easy. Narrow complex tachycardia, either sinus tachycardia or an SVT. تمام. The P wave, if the P wave looks normal, then this is most likely sinus tachycardia. If the P wave is abnormal, then this is SVT. Okay? Okay. Can I move forward? Okay. إنزين. Like I said, the P wave axis is towards, it's similar to the QRS axis or cardiac axis, is going towards the left and inferior leads. Okay? Okay. So in this case, طبعا, P wave axis is suggestive of sinus. Sinus rate usually is less than 220 minus age. And then in this case, it's obviously less than 220 minus age. Age is 14. So it's obviously less than 206. Okay, طبعا there's secondary cause. In this case, for example, febrile plus anemic. Okay, usually it's fluctuating rate, gradual increase, decrease, and there's PQRS sequence, of course. Okay. طبعا if you see a patient who's tachycardic بس يعني is resting, watching a movie, very relaxed, and his sinus, sorry, his rate is 200, and the P wave looks sinus, but you would not expect the patient to be tachycardic or in sinus tachycardia because he's so relaxed. Of course, you should suspect SVT even if the P wave looks like a sinus P wave, because that's an abnormal sinus behavior. Make sense, guys? I want to make sure I'm not very fast here, so please stop me. Yani sinus rate tachycardia, it should make sense. It should be physiological, appropriate for the patient physiological status. Okay. Agree? Understood? طبعا last time people were initially quiet, but then they started يعني be less quiet. So don't be shy. Okay? Hiba said okay. Okay. انزين. Okay. 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 So in case 2. So 5 years old with palpitation. This is the ECG. So what do you guys think? Like we said, there is tachycardia, then you have to ask yourself, is it narrow complex or wide complex? If it's narrow, then look at the P waves. Okay, so what do you guys think? Okay, Hiba saying SVT. Okay, Hiba, you're saying okay, SVT narrow, no P wave. Okay, yeah, I agree. Okay, guys, غير هبة يعني. What about the rest? Most probably SVT. Okay, Layla. Okay. طبعا why SVT? Because the P wave is not sinus looking P waves. There's absent P waves. I mean, it's not absent, but there is, sure. I mean, you cannot see clear cut P waves. Okay. Um, you do not see P waves, for example, in the inferior leads. You don't see an upright looking deflection that suggests a P wave. So you know it's not sinus in origin, and it's tachycardic, then you know it's fast. طبعا plus the heart rate here is what? The heart rate here is probably 254, 240, or even faster. So it's very fast. So you know it is against being sinus because the heart rate usually is 220 minus the age, and in this case it exceeds 300. It exceeds 220. Okay, guys, easy صح? Okay, heart rate 270. I agree. Okay, insane. Okay, so SVT. Okay, guys. Okay, so this was an example of a tachycardia that is narrow but not sinus. So in other words, SVT. And then you can further subdivide SVT into regular and irregular. In this case, it's regular, صح? But then if it's regular, this is your differential. Okay, AVNRT, AVRT, and flutter. Are you guys? You guys are mainly pediatricians, right? Am I correct? صح? صح, Dr. Ahmed, probably.
mainly pediatrician لكن في pediatric cardiologist.
Yeah. So يعني as a pediatrician, you probably should not worry about AVNRT or AVRT differences. As a cardiologist, you probably should try to distinguish between them. But I guess the majority are pediatricians. Yes, pediatrician, neonatologist. So, I would not worry about differentiate between AVNRT and AVRT. Okay, just know there are types of SVTs, and if it's regular, narrow complex, it's either AVNRT or AVRT or flutter. Okay, usually flutter is usually regular. It could be irregular, but it's usually regular. تمام. طبعا AVRT is usually regular. AVNRT is usually regular, but rarely it's irregular, but very rarely. So we'll not talk about rare stuff. Okay. Okay. So, okay. So that's ECG number 1, guys. Okay. So what do you guys see in ECG number 1? Is it tachycardia, yes or no? If yes, is it SVT or sinus?
السلام عليكم، مساء الخير.
سلام
آه
عليكم.
أنا أعتقد إنه في ال first ECG.
Mm,
I can it's obviously it's a tachycardic ECG. I think
yeah,
the heart rate is about 200 uh,
probably
plus
250,
200
240.
plus.
Yeah,
Yeah. And I can see if you can see in AVL, the AVL lead, you can see some P wave
yeah.
going on. It could be less obvious in lead three. I feel in lead three, maybe the P wave is more fused or very close to the QRS complex in lead three, but it's slightly more. It could indicate that there is on AVL and AVR. There's some you can see some P waves going on.
Doctor,
I
into
don't.
pediatrician or you are
No, I'm
cardiologist?
a pediatrician. I'm a
Okay.
pediatrician. I'm a
You were there
pediatrician.
last time, صح? Or
Yes,
no?
yes, I was there. Yes, I was
Okay.
there. Yes.
Okay, دكتور فيعني make it simple.
Yeah,
It's tachycardia صح? Narrow complex, not sinus
that's
صح؟ SVT
no,
period
yeah,
صح؟
that's
Okay,
correct. Yeah.
حلو. Everyone agrees? Okay, what about ECG number 2, guys?
Uh, I think shall I continue or someone else?
Yeah, go ahead دكتور. انت دكتور مدثر من
Yeah.
وين؟
So أنا من السودان. نعم، أنا من السودان.
يلا والنعم. اوكي كمل.
الله يبارك فيك. الله يجزاك خير. طيب في الاي سي جي الثانية you can see and I think for me I can see all the QRS complex and
Yeah.
followed by a wave that it looks more like a T wave more than I think it's a P wave. It
Yeah.
could be it's a tachycardia again. Sorry, it's a tachycardia. It's a neural
طبعا
complex.
it's one ECG one lead فيعني you cannot really tell بس
Absolutely,
can you its heart rate is very fast صح؟
absolutely, yes,
and يعني it's above 220 فيعني most
yeah,
likely it's an SVT صح؟ It's not
yes,
sinus
that's
صح؟
correct.
طبعا
Yeah, no,
plus
no,
you cannot really see a nice distinct يعني convincing P waves before a QRS طبعا you can imagine
yes,
stuff بس يعني if I tell you يعني if I tell you is it most likely يعني do you see obviously P waves that are يعني that are يعني you can be are you so sure that you see a distinct P waves you probably say no okay
no.
طبعا furthermore sinus rate is exceeds your what would you expect for a sinus uh,
Yeah,
rate, okay طبعا I'm not telling you the age of the baby but regardless it's above 220 okay for
yeah,
both examples are SVT ECGs صحيح guys okay agree everyone so SVT okay زين so now طبعا as a pediatrician okay what we said there are types of SVTs but regardless you wanna طبعا deal with the SVT of course يعني you can of course call the cardiologist بس يعني say you don't have a cardiology يعني in house what would you typically do for an SVT case patient what do you do typically in terms of management I mean if they are both stable but just in SVT so what do you do
so I think, yeah, you try to apport
yeah
the tachycardia or the
doing
SVT.
what
So a few options. So as one of my colleagues said, could be a carotid massage or vagal
طبعا carotid
stimulation.
massage we don't do it in pediatrics usually
Absolutely.
it's
Uh,
more adult
uh,
it's any
ice.
vagal صح
Yeah,
vagal or
yeah,
adenosine صح
yeah,
okay so again guys simple I'm trying to simplify arrhythmias for you because you guys يعني most people do worry about arrhythmias so much but in reality يعني most of the time you should not worry about it so much okay so both are SVT easy peasy you want to give vagal maneuver or adenosine حلو زين okay فطبعا again this is regular narrow complex not sinus because the P wave is not sinus in looking okay in other words SVT okay and طبعا يعني the way I teach people is a little bit different than what most people teach So you might be surprised a little bit, but this is just, I'm trying to be very practical, okay? If you follow what my scheme, 99% of the times you'll just figure it out, okay? Okay, عموما. This is شوية advanced. Oh, someone is writing Dr. Faiz. Okay, I don't know. زين عموما. you want if you wanna يعني you wanna طبعا do something either to terminate the tachycardia or help you differentiate the types of SVT. So in other words, you want to do vagal maneuver. طبعا usually what I do is adenosine, especially if there's any IV access already. Okay, but say we gave adenosine. In this case, we gave adenosine. Okay, so let's see what. So we give adenosine here. Okay, and طبعا this is very important. You have to do ECG recording during adenosine. هني in Kuwait, for example, most of the time people give adenosine and they call, oh, we gave adenosine and nothing happened. We gave adenosine, something happened. But yani, where is this something? No documentation. But this is unacceptable. And I'm sure this is the case everywhere. You guys have to record the ECG during adenosine, okay? So that's what we did here. And ECG number 1. So what happened after adenosine? Dr. Muddathir, you were trying to analyze the P waves. So there you go.
So you can see after the adenosine that you have a pattern of seesaw. Maybe it looks like an atrial flutter, P wave, and between every QRS, yeah,
flutter
yeah.
صح easy
Mm.
okay flutter فit was SVT صحيح like we said SVT could be regular SVT could be AVRT AVNRT or flutter صح this was an example of flutter SVT تمام so adenosine helped you clarify the diagnosis, did not terminate the tachycardia because adenosine does not terminate flutter, but it just helps you establish the type of SVT, and this makes a difference in terms of management for us, at least cardiologists or electrophysiologists. تمام؟ we want to tell what type of SVT it was because it helps us in terms of management. Okay? You might say, who cares? Just an SVT, whatever type it is, just shock him, for example. We care because flutter management is different than AVNRT or AVRT management. تمام؟ Okay. واضح, guys? Okay, I'm a little bit fast today because I think we have a little bit more slides than last time, so I worry that we will not have time. Best if you guys if I'm too fast, stop me, okay? Okay, clear, guys? Okay, so we gave identity for patient number 2, and this is what happened. So what do you guys see?
looks انه return sinus في الاخر.
Yeah, so يعني SVT terminated, صح?
SVT terminated
صح, and then went
Yes.
into sinus rhythm, صح? Most
Okay.
likely. And you have only
Yeah.
one ECG, one lead, so you cannot be sure, but heart rate went back to normal, presumably. This is probably a baby, okay? So heart rate is around 150, baby, okay? إنزين.
Okay.
فطبعا what else can you look for after adenosine if it terminates? What do you look for just in case?
لو في دلتا ويف وشورت بي ار
أيوة.
انترفال هيكونوا دبليو بي دبليو
Yes. Is there WW, yes or no? طبعا
نو
you can say no. I mean, honestly, I don't remember this patient, but if you look very carefully, there might be a hint of subtle delta wave. It's difficult for me to be sure without 12 lead ECG. I don't remember the patient, to be honest. My patient, I don't remember. So maybe, طبعا sometimes delta wave is very subtle, especially in babies because the AV node is so good, it hides your delta. So this is, I'm suspicious that there's delta, but there are better examples of this if there is true delta wave. Okay, guys? تمام? Okay.
Okay. تمام.
طبعا in just really quick, when you have this is probably more for cardiologists. When you have, when in baby, the AV node is so good, okay? Let's say you have a, accessory pathway here, your sinus node is here, it goes down the AV node and down the accessory pathway, and this is why you see delta wave. But if the AV node is so fast, so good, you don't see much delta because the AV node just masks your delta, your QRS is narrow, your PR is already short in babies anyways, but the delta is not as obvious because the AV node conducts really quick and masks your delta, which delta is a result of your accessory pathway activation. But if this is so fast, it will mask your delta a little bit, okay? فيعني you might not see delta, obviously delta wave in babies especially. With adenosine, when you block the AV node, you might see it, you will see it better, of course, okay? عموما, this is probably too advanced. I don't think it matters so much for you guys, for most of you. So again, with this is probably this is Dr. Joshua Cooper. He's an adult electrophysiologist, but has a very nice YouTube channel that you could see as well. So that's this is how the circuit goes in AV-RT. So it goes down the AV node, up a pathway, okay? Down the AV node, up a pathway. تمام guys? And then طبعا this is a patient of mine. It's a 3D like map. So this is just to orient you. This is the SVC here, SVC up top here. Okay, this is the IVC down. Okay, so anyway, and this is tricuspid valve. This circle in the middle is the tricuspid valve. So there's electrical activation rotating around the tricuspid valve, which is flutter. Okay, but if you block the AV node, the flutter doesn't care because it's not AV node. It's not part of the circuit. You will just see P waves more clearly. Okay. So your AV node is not required for continuation of the tachycardia in atrial flutter. So adenosine is ineffective, but adenosine would unmask your flutter waves. So it will help you confirm your suspicion or diagnosis. مفهوم guys? Clear? Will I repeat something? Clear?
clear.
Okay. Okay. Everyone is saying clear. المدثر. طبعا هبة والمدثر وليلى are the most active. Ahmed as well. Dr. Faiz. The rest are showing quiet, so I don't know about the rest. Okay. Anyways. Okay. Fair. Again, tachycardia, narrow, could be sinus or SVT, regular or regular. We talked about regular. So now with SVT, if it's regular, طبعا if you're an adult, you always think of AFib. Okay. طبعا in pediatrics, we think more of atrial tachycardia or irregular flutter. Okay. And with variable AV conduction. Okay. زين. طبعا now we're getting more advanced a little bit, but just so you know, if it's irregular, narrow complex tachycardia, there is a little bit more, or the differential is a little bit different. Okay. Okay. Here's an example. So a little bit more difficult. So this is I'm not giving you ages, but this is a patient that is 7, 8 years old, roughly. And what do you guys see? It's a little bit difficult ECG. So شوية يعني what do you guys think?
If the patient is 7 years old, so he is tachycardic,
Yeah.
and it is narrow complex.
صحيح.
B's are more than QRS, so
لا.
it is almost
Wait. What do you mean by P more than QRS? Where is the P's that are more QRS? More than Q?
and
يعني
the long strip. لا دي T. Sorry.
okay, so this is a P, صح? High T, okay? So there's one P for every QRS, okay?
QRS are more than B.
No,
No?
this is, yeah, P, QRS, this is P.
B.
All these are P's, okay?
Mm.
طبعا في P هنا at the tip of the QRS. P at the tip of the QRS. طبعا how do I know? Then this is how the T wave for this patient looks like. This is a different looking T wave, صح? So there's P up top. There's
Yes.
P
Yes.
on top of it, okay? But there's P on all these T waves, okay? تمام?
تمام.
But there is, Okay, so there's one P wave for every QRS, so 1-to-1 relationship. تمام؟
اوكي
زين. طبعا بعدين what happens here؟ شنو هني صار؟
يبوظ
Terminated.
terminate
بعدين this is a P wave. Is this P wave different than this P wave or same?
different
Different. حلو. So what do you
escape
think?
rhythm
This is يعني sinus rate. This is sinus يعني sinus node woke up and this is a sinus P wave most likely. طبعا you don't have lead 1, 2, lead 1 and 3 and AVF, but this is a P wave that is positive in lead 2, most likely a sinus P wave. بعدين another P wave came in that looks different صح؟ Bigger صح؟ طبعا yes both are positive but they look different صح؟ وبعدين
Yes.
tachycardia continues صح؟ Again there's one P on top of these T waves okay؟ ف tachycardia here okay? Not SVT, sorry, not sinus Y because the P wave looks different than sinus P wave صح؟ فthis is an
Yes.
SVT okay؟ لأن again قلنا شنو تعريف SVT؟ tachycardia with a P wave that's not sinus بس period okay؟ طبعا narrow complex tachycardia okay فthats SVT and that's SVT here تمام؟ زين this SVT is it regular or irregular؟
regular
لا شوف عدل من هذا زي ده
regular تقريبا regular
irregular
regular
this is two small or large squares this is two and a half large squares صح؟
صح
irregular okay okay فit's an SVT that is on and off on and off on and off and it's a regular narrow complex okay فطبعا again so differential is different ف it could be atrial tachycardia AFib or flutter تمام طبعا flutter with flutter usually there are more P's than QRS's تمام ف in this case قلنا في 1-to-1 relationship so it's not flutter فيبقى AFib أو atrial tachycardia طبعا بالAFib you don't see P waves anyways فهذيل you see P waves صح it's just they are there but different than sinus so it's an atrial tachycardia example okay I see so many people okay so P fused with T yes P on top of T صح S segment elevated I mean during tachycardia it's okay for S segment to get elevated يعني he's tachycardic he's you know in distress okay P fused adenosine irregular okay تمام مفهوم that's an example of atrial tachycardia ECG okay which is usually more difficult to figure out okay easy or I want to repeat that ECG
Okay.
okay this is how you analyze ECG يعني you take advantage of the pause in this case then you see a P wave that looks different than the P waves during tachycardia then immediately you know this is SVT okay then you see it's irregular and you see 1-to-1 you know it's atrial tachycardia it's not AFib it's either atrial tachycardia or AFib but AFib you don't see P waves so it's atrial tachycardia easy okay if you follow the algorithm it will be easy okay okay for that sinus so again this is the sinus P wave this is the tachycardia P wave okay okay guys انزين طبعا tachycardia P wave is just atrial tachycardia sorry just means there's an atrial focus outside the SA node that's firing rapidly so this is an example for example this is not by case this is from Twitter an example of atrial tachycardia that is coming from the inferior portion of the right atrium and it's just firing repeatedly okay كذي يعني going this way but P wave actually would be different looking okay and then when you give adenosine in atrial tachycardia what would you expect guys
It will not terminate.
صحيح it will not terminate okay if you know it's tachycardia then there's no point of giving adenosine it's silly يعني there's no point if you're not sure of course adenosine would help you but it's usually يعني you don't need to if you figured it out already زين so that's an example of a patient who is in tachycardia they gave adenosine you just see the P waves more clearly and then tachycardia resumes okay زين عموما in other words so when you have tachycardia that's narrow this is how you should approach the case. Okay, it's not that difficult. تمام. خصوصا يعني especially in pediatrics where we don't have AFib يعني you have one less differential. Okay, انزين. Okay, now we're gonna talk. Any questions before we move on? Okay, انزين. حلو. Okay. Okay. So now we're gonna still tachycardia, but more different type of tachycardia. Okay, so that's 2-year-old patient with palpitations. So now we're gonna get to more advanced ECGs. I'll try to simplify things, but يعني it's a little bit more cardiology or senior pediatric level, okay? Okay, for 2 years old with palpitations. So what do you guys see?
Wide complex tachycardia.
Okay, hello, wide complex tachycardia. طبعا ال QRS duration depends on the patient age. طبعا the smaller the patient is, the narrower the QRS, the bigger the patient is, then wider the QRS. So you have to look up the numbers. But in this case, it's definitely wide. طبعا it's 2 years old, so it's a baby. And you know, that's a wide QRS for a baby. Okay? تمام? This is a wide QRS for a baby. You have to train your eyes, okay? When you see the QRS is like this widely spread, this is definitely wide for a baby, okay? طبعا not for an adult, but for a baby. Anyways, for wide complex tachycardia, regular or irregular?
Regular.
Regular. حلو. Do you want to say anything else ولا خلاص؟
So it should be VTAC or supraventricular tachycardia with aparacy.
حلو. Okay. تمام. fair. So now we are tachycardic, we are wide, صح? Then regular. طبعا regular. Furthermore, you can say it's could be monomorphic or polymorphic. تمام. طبعا in this case it was more monomorphic, صح؟ صح؟
صح تمام.
Okay. انزين. It's tachycardia, wide, regular, and monomorphic. Then you have differential. طبعا now it's a little bit complicated. Dr. Ahmed, mashallah, already said a couple of things. So you could be in sinus tachycardia with aberrant or a baseline bundle branch block QRS. Or you could be in SVT with aberrancy. طبعا شوية this I will explain this in a second. Or you could be in something called antidromic tachycardia or VT. إنزين. Okay, so I'll try to simplify things. Okay, so imagine, so that's your heart, okay? تمام. Okay, and I think I have also cartoon like further like when I just advance the slide. So anyways, imagine you have your sinus node here, and then it goes down to the AV node, صح? Imagine you have a patient with surgery and there is no right bundle. The right bundle is cut off. Okay. So during sinus, for this patient, the sinus rate would be, sinus QRS, sorry, would be P. And then you would have wide QRS because there's no, there has intrinsic right bundle branch block. مفهوم? So if you have sinus tachycardia, you would have tachycardia that's wide complex because the QRS intrinsically is wide complex. Agree, guys? Makes sense? This is what I mean by sinus with baseline bundle branch block. مفهوم, guys? Well, I repeat. That's important
معلش لو
concept.
كده يا دكتور أحمد، معلش
Sure?
استاذن حضرتك بس تعالى الجزئيه التاني.
Okay. So let's say you have a patient who underwent cardiac surgery in the past, and the right bundle was cut as a result of surgery. Okay? Which happens many times. Okay? يعني the right bundle got injured during surgery. تمام? So the patient would come out of surgery with right bundle branch block صح? Or with wide QRS pattern. مفهوم?
تمام.
If this patient went into became febrile, he will get his sinus rate would go up, so he will have sinus tachycardia, but it would not be sinus tachycardia that is narrow complex, then his baseline QRS is wide. But sinus tachycardia best with wide QRS لأن he has intrinsic bundle branch block. For example, right bundle branch block. مفهوم؟
تمام. شكرا جزيلا.
when you see P wave that looks like sinus followed by QRS that looks like a right bundle or left bundle, then this is sinus tachycardia with bundle branch block. Yes, it's wide, but it's not VT. Okay? And then, or if the patient goes into SVT, when the patient goes into SVT, oftentimes the conduction goes down the AV node. Like, remember when we said the conduction goes down the AV node, upper pathway, صح? When it goes down the AV node, it might block down the right or left, and then it just uses one limb of the AV node, okay? So this is why some patients with SVT, they get aberrant conduction down left or right bundle. So the SVT for that patient would be wide QRS because it is in fact SVT with aberrant conduction. تمام؟ not every SVT is narrow complex. لأن أحيانا the right or left bundle gets blocked during SVT. مفهوم؟ It's a little bit too advanced for a pediatrician or neonatologist, but I'm trying to simplify it. Okay? Okay, أنا عندي رسمات anyway, so let me use my diagrams here. Okay. Maybe it will make things easier. Okay. زين. Okay. Okay. So again, this is an example of a patient with right bundle branch block. Yeah, the right bundle is diseased for whatever reason, usually surgery. So you go down the AV node, down the left bundle. Okay. So you will have left bundle branch block morphology, and if the patient goes into SVT, it will go down the AV node. It will go down the AV node, down the left bundle, up the excessive pathway, and so forth. Okay? Guys, just a second. Hello.
اوكي تمام.
Okay. As in, antidromic tachycardia just means instead of usually you go down the AV node up a pathway, you're going down a pathway up the AV node. So it's the reverse circuit. So you're going down an accessory pathway. Okay? So you're going down an accessory pathway up the AV node. So your QRS would be wide because you're not going down your AV node. The QRS is narrow usually because you're going down the AV node into the right and left bundle and his Purkinje system. So as a result, your QRS is nice and narrow. If you're going down the ventricle elsewhere outside the AV node, his Purkinje system, your QRS would widen. Okay, because you're not using your normal his Purkinje system, so you're activating the ventricle muscle by muscle, muscle through gap junctions, muscle to muscle, muscle to muscle, so the conduction would take forever to be completed. Versus if you're going down the normal his Purkinje system, everything is rapidly conducting at the same time, so your QRS duration would be narrow. مفهوم؟ But antidromic tachycardia means you're going down an accessory pathway up the AV node. العكس Orthodromic tachycardia means you're going down the AV node up a pathway. اللي هو AV-NRT or AV-RT AV-RT, sorry. Okay? Okay, guys? شوية this advanced. You don't have to worry about this so much. Another differential is ventricular tachycardia. Okay? Meaning you're having a circuit in the ventricle only. So, of course, the QRS would be wide. Okay? Ahmed, easy? Dr. Faik,
ايزي ان شاء الله. ايزي.
easy? Okay, مدثر. هبة لبنى
اوكي
ليلى كلكم تمام؟ اوكي زين اوكي سو زين طبعا again طبعا there are other stuff in this ECG I will not talk about so much but for people who are cardiologists maybe they wouldn't want to know that. So again, wide compass tachycardia regular, and there is something called AV dissociation. So the P's are just marching through irregularly, but this suggests ventricular tachycardia. But I will stop there. I will not go into details. Then I don't think we have to go into details. Okay, but that was actually a VT case. تمام? Okay. زين. Okay. So that's a patient with tetralogy repaired. Okay. Post-op, a little bit tachycardic. I'm not giving you the age of the patient, but let's say he is يعني 1 year old, okay? So he's a little bit tachycardic. Heart rate is what?
around 150.
Okay, حلو. So a little bit tachycardic, okay? Again, what type of tachycardia? Narrow or wide?
Wide
Wide
complex
complex.
tachycardia.
حلو. So is it sinus with bundle branch block, or is it SVT with aberrancy, or is it VT? What do you guys think? Or is it endodomic tachycardia? طبعا with endodomic tachycardia with VT, you would not, the P wave would be شنو؟ يعني
لو
with endodomic tachycardia, you would not see P waves typically. You will not see them, or the P wave would not be sinus looking P waves, okay? But in this case, the P waves are sinus looking P waves, yes or no?
yes, there is some bees here. Oh, yes.
So P wave here, صح؟ طبعا this is a clear P wave. So P wave positive here, positive here, positive here, positive here. ف direction of the P wave is شنو؟ Sinus, صح? You're going towards the left and towards the inferior. صح؟ فit's a
Yes.
sinus يعني P wave and the patient tachycardic. So there's sinus tachycardia plus white QRS, which is يعني a patient underwent
Underbrain.
surgery. So with tetralogy, would you expect the QRS to be wide or narrow after tetralogy most of the time?
Wide complex.
Yeah, because they usually would injure the right bundle. And
Right bundle.
this is an example of a right bundle branch block QRS morphology. Okay, but this is an example of a sinus tachycardia with a wide QRS or sinus tachycardia with right bundle branch block. Okay, تمام.
تمام.
Okay, insane. This is AVSD patient who is post-op. تمام. This is our patient post-op. They called us. He's tachycardic. طبعا heart rate is يعني I don't know. Heart rate is 180 maybe. شوية faster than 150 or 160 let's say. زين. The post-op heart rate 150, 160. Patient is like 6 months old roughly. So it's a little bit tachycardic. زين. But again, sinus or not sinus, wide
Not
or narrow
sinus.
complex, not sinus, you don't see P waves, صح?
Yes. And
حلو.
wide complex.
And wide complex, تمام. It's not sinus tachycardia with intrinsic bundle branch block. زين. It's regular wide complex tachycardia. حلو؟ صح؟ Regular wide complex tachycardia, not sinus. Okay. طبعا with after AVSD repair, would you expect the QRS to be wide or narrow? I mean, or not would you expect? Is it يعني is it possible for the QRS to be wider after AVSD repair? Yes or no?
Yes.
Yes, because there's a VSD component, they close it, the right bundle often gets injured. تمام? Okay. And the QRS looks like a right bundle morphology QRS, upright in V1. طبعا with AVSD usually you have left axis, this is intrinsic with AVSD عموما. your differential could be SVT with intrinsic يعني aberrant with intrinsic bundle branch block, or SVT with aberrant conduction, صح? This is one differential, صح? Or VT طبعا, صح? Or antinomic VT, SVT, tachycardia, antinomic tachycardia. تمام? صحيح guys? Everything is possible except sinus tachycardia in this case, صح?
صحيح.
Okay. So because SVT is in your differential and it's regular, you can give what?
أدينوزين. نعم.
حلو صح.
مم.
Okay. فوي gave شنو adenosine here. Okay. زين. Why is it called SVT not jet doctor? Okay. Jet is also a differential. طبعا jet is more advanced. I don't know Dr. Shams, I guess. Amr Shams. I don't know whether you're a cardiologist. But yes, jet is also possible. Still in the differential. Jet is usually more irregular. Usually, this is regular, but still in the differential. Okay. We gave adenosine. Okay, so let's see what happens with adenosine. So this is what happens. So what do you guys see?
terminated يعني التاكيكارديا terminated.
حلو صح.
بس يعني وفي بي
Tachycardia
رجعت
terminates. Okay. If tachycardia terminates, could it be VT?
no.
No. حلو. So VT is out of the equation. طبعا rarely it could be, بس يعني we are simplifying things. It's not VT. تمام. It could be SVT with aberrancy or antidromic SVT. By the way, jet for Amr. Would jet terminate with adenosine? Yes or no? I mean, it's an advanced question, but the answer is no. Okay. Jet usually doesn't get terminated with adenosine. حلو. Amr said already no. It's not jet. Okay. إنزين. حلو. now يعني it terminated صح؟ إنزين. could it be sinus tachycardia by the way? No. Okay, adenosine does not terminate sinus tachycardia. حلو. now what you see is a sinus P wave here, positive indeed 1, 2, 3, small, okay. AVL positive, AVF positive. Anyway, sinus P wave, followed by a QRS that is a little bit wide, okay. إنزين. هل QRS is exactly the same as your tachycardia QRS صح؟
yes.
Okay. But now you know it was SVT with baseline bundle branch block because of surgery. لأن the baseline is bundle branch block. Hello? But this was SVT with baseline bundle branch block. مو SVT with aberrancy أو مو SVT that يعني a patient did not go into SVT and then aberrantly conduct SVT. He already had aberrant conduction from the beginning. تمام؟ It's what SVT with intrinsic bundle branch block. تمام؟ Okay? SVT with baseline bundle branch block in this case. مفهوم guys? Well, I repeat. You don't need to know all these details by the way يعني بس يعني this is meant for advanced يعني advanced clear advanced يعني those who are interested in cardiology a little bit. Okay? Okay. عموما. Okay. Okay. إنزين. Okay. إنزين. This is I'm repeating myself here, so we're going. This is an example. Some people are okay. People are just using the pen as well as on my screen, so please don't do that. So we're going down the AV node, okay, up a pathway, okay. So this is called orthodromic SVT, and then when you give adenosine, the tachycardia would terminate and the QRS would be same. If you're going down the AV node, okay, and then blocks, for example, here in the left bundle, goes down the right bundle and up the pathway, okay, so the QRS would be wide, then you're blocking down left bundle, okay, and then when you give adenosine to terminate, but the QRS would become narrower, then left bundle was not diseased, just was not conducting during SVT because it was too fast for it to conduct. But after this rate came back to normal, the left bundle would work as normal. Okay, يعني if you have intrinsic left bundle branch block, طبعا the QRS would remain the same. If you have a left bundle or right bundle that aberrates during SVT, the QRS would narrow down after you terminate tachycardia. شوية advanced, بس يعني you don't have to worry about all this شوية, unless I mean if I can repeat myself if you guys are interested, بس يعني it's a little bit advanced. Okay, clear guys?
معلش يا دكتور احمد، يعني هي لو اس في تي ويز ابيرنسي الكيو ار اس كومبلكس هيرجع تاني للنورمال
Yes.
نارو يعني
صح.
سوري بعد ادونيزين
Yes.
صح كده؟
So if you have SVT with aberrancy, you give adenosine. طبعا it will present with wide QRS tachycardia. You give adenosine, terminates into narrow complex يعني sinus rhythm. If you have SVT with intrinsic baseline bundle branch block, it will present as wide complex tachycardia as well. You give adenosine, it will remain wide complex, but the rate would be normal. مفهوم؟
كلير. شكرا
Clear?
جزيلا.
Okay. زين. Again, orthodromic SVT just means you're going down the AV node up the pathway. Antinomic SVT just means you're going down the AV node. Sorry, down the pathway up the AV node. Okay. Okay. Again, you give adenosine here, the QRS would remain the same. Just the rate would come down. You give adenosine here, the QRS would change and slow down. Okay. Yes, agree?
Yes.
Okay. Again, too advanced for you. And then we are approaching. Okay, it's 8:30. Okay, so we're back to the initial ECG. We said this is VT, remember? And I mentioned we gave adenosine here. We said it's VT anyways because of the AV dissociation. Okay, which is a little bit too advanced. But when we give adenosine with VT, it will not be affected, صح? So we gave adenosine here, and there's no change in tachycardia. But it was resistant to adenosine, confirming our suspicion of VT. Okay, guys? This is ECG number 1 that we during like ECG, the first wide complex tachycardia ECG that we show. Okay. We gave adenosine again, nothing happened, which makes VT more suspicious. And طبعا, provided you gave the adenosine with good technique, good dose, good flush through a large IV access and so forth. Okay. زين. Tachycardia, wide, regular, you have these differential that we mentioned. Okay, زين. I think we have a couple of more slides. Let me see how many slides we have. We have, okay, yeah, we have 3 or 4 more slides. So we're almost done. Okay, so 8 years old with palpitations. What do you guys see? Tachycardia, yes or no?
Yes, wide complex tachycardia.
Hello, wide complex tachycardia, regular or irregular? طبعا because it's very fast, it might be difficult to tell, but it's irregular, صح? Irregular, صح?
Yes.
Okay. Irregular, polymorphic, ugly looking, tracing. Okay, most people said VT. And then, طبعا VT is differential, of course. Okay. Okay. طبعا heart rate is very fast. The patient was stable-ish, but يعني drowsy. So if you see irregular wide complex tachycardia, what do you typically do? Do you give adenosine, yes or no? I mean, say the patient is not that sick, but you should not give adenosine. Okay. Wide complex tachycardia, irregular, you don't give adenosine. Okay. زين. طبعا there is a reason for that. I mean, I can explain it, but يعني again it's an advanced question. So tachycardia, wide, irregular. Remember our irregular differential with narrow complex is almost the same. So you can have atrial tachycardia with aberrant conduction. You can have AFib, okay, with WW, which is usually polymorphic, or you could have a regular VT or polymorphic VT or VF, okay? Okay. طبعا this atrial with aberrant conduction just means there's a focus in the atria that's firing rapidly and going down the AV node with aberrancy. So it's wide. It's irregular and wide. Okay? AFib with WW, this just means that the patient is in AFib. with intrinsic WW. So then you will have variation of delta or widening of the QRSs because there is different rates of the atrial contraction, different inputs into the accessory pathway. So the QRS would change beat by beat. So the patient would usually present with irregular, fast, and polymorphic QRSs. Okay, طبعا this is advanced. We're now heading towards the most advanced part of the lecture. Okay, and then VT could be regular or regular. Polymorphic VT is usually irregular, VF is usually irregular. Okay, so this is your differential. Okay, and then so the take-home message here is do not give adenosine if you see irregular rhythm that is wide or polymorphic rhythm that's wide. And guess what? This patient, they gave adenosine, which is incorrect. Okay, so that's why I'm stressing this point. You should not give adenosine. Okay, then by giving adenosine, you might you might طبعا unintentionally like the rhythm might degenerate into VF if you give adenosine. Okay, with such rhythm, so you have to be careful. Okay, and then so what you do instead, usually you have to shock the patient. Okay, or you give IV procainamide if the patient is stable, but we don't have IV procainamide in Kuwait. Okay, so we shock the patient. So now post-shock ECG, what do you guys see? Same patient.
يعني التاكيكارديا terminated وفي lead to في بي ويف.
اوكي صح.
دلتا ويف.
في دلتا
حلو.
ويف.
short PR delta wave. اوكي تمام.
Yes.
But there's a short PR delta wave. اوكي اوكي زين. the patient in retrospect the patient does have WW, we know, and then was in AFib. Was in AFib. Okay, طبعا WW patients they are at higher risk for developing AFib, and then this is why sometimes the WW patient we take them seriously because they are at risk of sudden death because they get AFib, and then the AFib conducts down the accessory pathway very rapidly, and then the patient goes into polymorphic or ventricular fibrillation. So that's why they might die suddenly. That's why WW patient, we take them usually seriously. We try to ablate them to avoid sudden death risk, which is rare, but present or possible. Okay, and that's one example, and in an 8 years old. Okay, okay. So in retrospect, the patient was having, yes, most people said VT, which is a very fair differential, but either way, you have to shock the patient or give IV procainamide. So we shock the patient. We saw delta wave. We saw WW. So we know it was WW with AFib. Okay, and we ablated the patient. Okay. Okay.
Dr. Mohammed, Masha, question. Here we don't give adenosine in order not to block the AV node, and so the impulse will go through the accessory pathway and make VF.
Yes, صح. Okay. And then we don't give amnio, same thing. You don't want to give anything that blocks your AV node and promotes conduction down the accessory pathway for Dr. Amr Shams. Okay? Okay, I think this is the last case. This is like infant or newborn who had such tachycardia and arrested during that ECG. He was intubated, so it's a nice tracing, but there was no pulse during. So what's this?
polymorphic VTAC.
Hello, polymorphic VTAC. Okay. زين. Pulseless, you have to shock the patient, of course. Okay. زين. Okay. So that's an example of polymorphic VT in a newborn. Okay. That's 1 day old fetal. He had history of tachycardia and cardiomyopathy, and he had pulseless arrest. Okay. زين. تمام. So I showed you an example of AFib with WW. I showed the example of polymorphic VT. I don't think I'll show you any further examples, but that's in general how to approach tachycardias that are wide or narrow. Okay, so this was an overview. I would recommend you guys organize your thoughts and have a specific algorithm that you like, and then study the ECG and follow that specific algorithm. Okay, طبعا I did not discuss stuff that are not usually relevant for pediatrician or neonatologist, and we did not talk about management so much, but I don't think you guys need to worry about that. So, okay, so I think we are almost, yeah, time is up. So questions, guys?
What's the drug of choice in ventricular tachycardia?
Depends on what type and stuff. It's a very broad question. For example, if it's vesicular, you give calcium channel blockers, verapamil. If it's, something else, if it's long QT related, you give something else. If it's idiopathic, you give something else. Depends, there's no one drug of choice for each and every VT. Okay.
Okay.
في البيشنت with WBW يعني ايه اللي drug of choice للاريزميا لو همشيه على
No, you
حاجة
have to ablate. You have to, because if you have ablation option, you have to ablate. If you don't have ablation option, you give flecainide.
flecainide.
Yeah, if you don't have ablation option.
Yes,
But
yes.
the treatment of choice or management of choice is ablation. That's life-threatening.
Yes.
Okay, you should not discharge the patient. You should admit, do ablation and discharge thereafter. Okay.
احنا احيانا بنعطيه مثلا appointment للابليشن ده فبياخد مثلا شهر شهرين او حاجه
غلط.
شبه
You
كده.
cannot pre-excited AFib, you cannot discharge. If you have a early patient, sure, you can give an appointment even after a year. It's okay. بس someone presented with pre-excited AFib, this means that he might he is at risk of sudden death. Okay. My battery is running low. Okay. He's at risk of sudden death. Okay. You cannot discharge home. I mean, you should not. You can give flecainide if you have no option for ablation, but if you have option, you should على طول offer ablation.
Okay.
We just
Thank
had
you.
a case like last week, but not pediatric, شوية older, but again, you admit, you keep, you do ablation, then you discharge. Okay, that's the standard of care, or like how you should approach such a case. Okay.
Okay, thank you.
Okay. Questions? عموما it's
Dr.
recorded.
Mohammed,
Yeah.
a patient with supraventricular tachycardia and aborted by adenosine. Should we give all patients antiarrhythmic drugs or certain patients?
عيد.
The patient with supraventricular tachycardia and already aborted by adenosine.
Yeah, طبعا.
Should start antiarrhythmic beta blockers to all patients or certain patients?
لا, I usually give to all patients. I offer ablation. If they don't want, I offer them therapy or observation. بس you most likely, the patient most likely would require ablation at some point. So I usually, but I tell them SVT is not life-threatening. You don't have to give medication to do ablations, up to you, but expect repeated attacks, and then you have to visit the ER. So it's the parent's choice, of course, but they have to understand it's usually the patient will get repeated attacks of SVT, and they should know how to manage or deal with it, like with vagal maneuvers, ER visits, and so forth.
If it is the first attack, we give him medication or not?
This concept of first attack and then it might just never come back, this is it almost always comes back. طبعا it might come back after 2 years, but almost always comes back. This notion of one time if you don't treat, wait for the second attack, I don't follow that. I'm not from this school of thought. I usually tell the parents it will come back, and most of the time it will come back. Very rarely it doesn't come back. عرفته؟ it's false hope and it might not come back. Let's wait for the second attack. It's almost always comes back. Okay. I usually tell them you don't have to treat, but expect it will come back. So if you don't want it to come back, you should treat or do ablation. Okay.
Okay, تمام. Thank you.
Okay.
ماشي. بالحالات اللي هي الانسيسنت تاكيكارديا يعني احيانا دخل معانا حاله اس بي تي وكانت يعني اعطينا ادينوزين اكتر من مره وما كانش فيه ريسبونس. هل في ابروتش معين لحالات شبه كده؟
طبعا again ما فيش response مفيش response meaning it terminates and then came back ولا there's no response like meaning nothing happened في فرق. So you have to again that's why you have to be specific and you have to show me what do you mean by no response.
it
So what
didn't
do you mean?
terminated يعني هي still SVT العيان
كويس يعني if you give good dose good technique adenosine it should terminate but it might terminate for 2 beats and then comes back. If it doesn't terminate at all with good technique then there is something it might not be SVT it might be junctional tachycardia it's something funny it could be atrial tachycardia عرفتي؟
لا هي سوري يعني هي فعلا aborted بعد كده رجعت تاني بس نشوف طيب
don't say no response that's a different that's incorrect just say transient response يعني be careful with your wording. So if it terminated and then came back this just tells you the patient needs medication you have to give IV medications IV as malol IV sotalol IV amiodarone IV something and wait for the medicine to يعني couple of hours and then repeat the adenosine.
ايوه يعني اعطي ادينوزين بعد كده امشي على IV اميدرون او ستالول فور مثلا
You have to wait for give 2-3 hours of IV drug and then repeat adenosine and then usually it might it terminates and then just doesn't come back. طبعا sometimes it does come back so you have to wait more give more drugs. يعني it's a complex question and يعني we have a patient now in our ward with 3 drugs. يعني IV amio, IV esmolol and oral flecainide to stop the SVT. It's a baby. It happens بس يعني it depends يعني. You have to involve cardiology in this case يعني you are a pediatrician صح؟
لا انا كارديولوجي
انت كارديولوجي اوكي دكتور فيعني you have to involve elective or something يعني patients are يعني you might need to give 2 IV drugs 3 IV drugs يعني it depends.
اوكي
Okay. Okay.
اوكي ثانك يو دكتور.
Okay. Okay guys thank you.
شكرا دكتور محمد. Thank you very much.
مع السلامة. مع السلامة.
شكراً.